Hi, I'm Dr. Jeffrey Annamarino from Bellissimo Plastic Surgery and Medi-Spa. Welcome to our Facebook Live event. Today we're going to be talking about breast augmentation, and we thought it would be fun to walk somebody through a mock consultation with me for breast augmentation. So we have Beth here tonight. She's part of our team, and she agreed to go through the consultation with me. She's going to be asking me just random questions that she's heard about, but I'm going to go through exactly the process that I go through with every breast augmentation. So if you have any questions, please feel free to let us know, and I'll be happy to answer them for you. But tonight, all about breast augmentation and with every detail. So welcome, Beth.
Hi, thank you.
Okay, so today we're going to talk about breast augmentation, and I usually start the consultation with asking the patient where they have found out any of their research. So many of the patients have gotten it off of the internet, or they have seen other surgeons. So in this case, you've probably got it off the internet. So,
yes, yeah.
Right.
I've seen your website. I've looked through the sources you've shared on your website, and I've seen some other surgeons in the area, but I'm really here with an open mind to hear more about what you have to say today, so I'm excited.
Good. So we're going to go through everything you want to know about breast augmentation and maybe some things you don't want to know. But so whatever you've learned, that's okay. It's great to bring with you, but I'm going to go through this like you've never heard it. I want to be able to make sure that you and I are on the same page. And so any questions that you have, feel free to interject. Anything that you've read, anything that you've heard from other surgeons that might be a little different, feel free to ask. But this is how I take everybody through it. So for starters, there is a difference between silicone and saline. Both are good implants. Preferably, I like silicone implants over saline. You can feel this. This is a nice soft implant. These are all silicone implants over here. Reasons I like silicone better than saline. Saline implants do the job. They give you the volume. However, they tend to ripple. And so if I have a patient who's really thin, you can see sometimes some rippling through the skin. You can always feel a saline implant, especially on the side. So women that are, especially when they're really thin, you can feel it. So from a matter of having confidence, that kind of bothers them. The other thing that I like about the silicone implants, they're soft. They feel just like breast tissue. You're not going to feel this implant. The one that I use now, we'll go through those different styles in a few minutes, but this style has been out about 5 or 6 years. It's from Allergan, which I really like. It's a little bit more filled, so you don't feel, there's no knuckles to it. So this one here is the one I used to use. It's a little bit underfilled, so it has a little bit of an edge. So the chance of this one rippling is very small. So compared to a saline implant that tends to ripple in just about every situation. The silicone implant, the silicone inside is like a jelly. Years ago, the old implants were like a molasses. This implant, if I cut it in half, the jelly would just sort of sit there. It doesn't go anywhere. So,
yeah. And I have a question. You said the thinness of the woman. Is that the thinness of her skin? And is that something you can tell during a consultation, or is that something that you can see?
Yeah, that's a great question. So it's the amount of breast tissue she has, plus also the thickness of her skin. So. And I don't mind doing, video consultations with patients, but nothing replaces the face-to-face, because then any surgeon can examine the patient. They can really judge the texture, the thickness of the skin, how much breast tissue they really have. Also, the distribution of breast tissue through the breast. So the breast tissue is really made up of some fatty tissue and breast tissue. So it's really nice to know that, because you're going to be putting in something behind it that's going to enhance it. So you want to make sure that breast tissue is evenly distributed, and it usually gives you a better result. There are some women where the breast tissue is really, sort of centered behind the nipples. Sometimes it's out on the outer part. So it's nice to know that you can't get that from a video consultation. So I like to have that.
The width of the breast tissue can vary depending on the woman then.
Right. Okay. So the body habitus of the woman really, reflects in the width of the breast, how much projection. Breasts come in all different shapes and sizes. Some are round, some are a little bit more conical. Sometimes you have a tubular breast deformity where there's some breast tissue herniated into the nipple. Sometimes the upper length from the top of the breast to the nipple is longer than the lower part, and we call that a constricted lower pole. So these are the things that the surgeon really needs to know, because that can make the surgery a little more complex, a little bit longer, and So, and the outcomes may take longer to get to your final outcome, depending upon how much work you have to do in the dissection. So these are all things that I like to see firsthand, get a feel for, take my measurements, and we'll go through that in a little bit.
And you said body habitus. What does that mean?
So really just the build of the woman. So some women are real tall and lean. Some have, really bigger bone structure. Some have more breast tissue. Breasts can also be completely different from side to side. So some women have a larger breast on one side. Everybody knows, even for men, one side is a little different than the other. But sometimes you can have a large hanging breast on one side and almost no breast development on the other. You can have differences in the pectoralis muscle. The other thing is you can have differences in the bony structure underneath. So one part of the rib cage might be sitting back further than the other. So, and that really makes a difference when you're putting an implant on that foundation, that even though the breasts look similar in volume, if one set of one rib cage on the one side is set back a little bit, that implant, even though they should be the same size, you might need a bigger implant on the side that's set back a little bit to give you that extra projection to overcome that difference. So there's a lot of things that go into the surgery, and this is a lot of the stuff that I like to discuss at the time of the consultation. We can go through a lot of that stuff so the lady really kind of knows what to expect.
So it sounds like some things you may not know until you're in surgery.
Definitely the rib cage, unless the woman has something called a pectus excavatum, and that really is sort of the divot, in her chest wall, and you can see that on examination. But subtle differences, but even just a few millimeters off, you won't know until you're in surgery. So along the rib cage, even just like I said, 2, 3, 4 millimeters, implants from one size to the next only vary in millimeters of projection. So if one set of rib cage is set back 3 millimeters and you think you're going to use the same implant going in, you might need 1 or 2 sizes bigger to overcome that. And so that's something you find out when you're in the operating room.
That's great. Perfect.
Okay, so again, back to that silicone gel. The silicone gel is safe. I like it. It's a natural feel. The other thing is the longevity of the saline implant versus the silicone implant. Saline implants on average last about 15 to 20 years. Silicone implants are going to last at least 30. So from that standpoint, I think you're going to go through less surgery in the long run going with silicone at the beginning. So that's been my choice. So, but we talk about it, and if a woman really wants to go with saline, I give her that choice. But most women, once they hear all of that, stay to the silicone side. But again, that's something that I would accommodate a woman.
And these are both saline or
both of those are silicone. So
okay.
Everything over here, and this one's silicone as well.
Great. And is there a difference in the size between these two, or?
So difference in style.
Style.
These are, so this one here, I don't know if you can see it on the screen. This is an older style. It's a wide flat implant. I've never been partial to this. I use it once in a blue moon, but this doesn't really look much like a breast. A woman's breast should be projected, but you really shouldn't have a lot of width. So as we're going to talk about in a few minutes, I have 3 non-negotiables. One of them is the size of the implant. A wide breast does not look good. It makes women look top heavy, whether you're tall and lean or just a different body habitus where you might just be a little bit shorter, a little bit wider. It's going to make you look top heavy, and it's something you can't disguise in clothing, and it's not something you're going to like. So I've never been partial to this one. This was the one up until about a few years ago. This is a high profile. These are all the same volumes.
When you say volume, what does that mean?
The amount of gel inside each of these is exactly the same.
Wow.
So completely different shapes. And so you can see, depending upon what the woman, what her breast tissue looks like and what your outcome is supposed to be, the implant may change and your choices may change.
Yeah, this is interesting.
Yeah, so this one is the one I used to use because there were only those 2 to really choose from. This one was a nice balanced implant. The only criticism I have is it was a little under projected. This implant came out about 5 or 6 years ago, and you can see it's just slightly more projected. And when you tilt it this way, it's slightly more narrow in its diameter. So the nice thing about this implant accommodates most breasts and most women because you can actually get the projection you want without the width, and you don't have to go to a very big implant. So there's some women that come in and somebody's put in 550, 600 cc's. of that style. It's a very big implant, trying to get the projection because there's not much there. This one, you can stay with a much smaller implant and get the projection you want. So you get that nice fullness. Today, a lot of women want a natural look, but they want that nice balanced fullness. And this implant for me has really been a game changer, even compared to the one I used to use. And this one I still really like. It was a great implant. This one really is just the best one on the market in my opinion. So this is the most common one that I use, even for my reconstructive patients.
It's very interesting that they're the same
volume,
but the diameter is so different.
Right. So women that come in, you've been looking on people's websites, you come in and you say, you know what, I saw this picture, I saw it on somebody's website, they have a 300 and some cc implant, that's what I want. But until you try them on, and we don't know the style of that implant. So the style really matters, and that's the shape of that implant. Even though they're all round, there's different projections, different widths. So we need to, basically match that up with the woman, and depending upon what her goals are, we have different choices to make. So the majority, this one actually is very good for them. So that being said, choosing this, we do at the time when I size you, and I do that sort of at the end of the consultation. So getting back to my 3 non-negotiables. So number 1, size matters. So one of the measurements I take when I examine a woman is the base width of her breast. And it can be anywhere from 10 to 15, 16. It just depends on the woman.
Is that this way? What do you mean by
base? It's just the actual base width of the breast.
Okay.
So from the inside part to the outside part. Now, a woman's breast should stop at the front part of her armpit, and so should the implant. So whatever that number is, that diameter, I will go to that or 5 millimeters wider. So very common number is 12. So 12 centimeter width. I'll go to 12 and a half. Bigger the implant, the wider it gets. So when I try on implants, I will allow her to choose all the way up to that diameter. Once we get outside of that, I won't do the surgery because a couple of complications. Number 1, we talked about the wider that implant, the wider she looks. Once that implant goes past the front part of the armpit, it's no longer aesthetic. It looks too bulky and you just can't pull it off. That's number 1. Number 2, it's a foreign object. So there is a chance that implant's going to move. You've probably read about bottoming out or women lying down and the implant moving toward the armpit. It's very common when the implant's too wide. If the implant is fitting that woman's anatomy, done in the right way, not over dissecting the pocket by the surgeon, in the right size, your chance of that happening is maybe around 2%. You start getting up into those high numbers, especially for this one, because it's so wide, you might be 25-30% risk of that moving, and that means more surgery down the line where you have to go in, do pocket revisions, replace the implant, and it's just more money and more downtime. So my feeling is we try to do everything at the beginning to decrease your risk. So size matters, shape matters, and that's number 1.
I have a question about that.
Yeah.
I've heard other surgeons say that they're willing to give me a larger size. Is that bad, or should I steer clear?
Again, it's preference.
Yeah.
So some women will come in and say, I just really want to look augmented. I want that big full implant. It's the surgeon's choice whether they're going to want to do that or not. My choice is not to do it. I'd rather walk away because I want to decrease as much of the complications that are involved as possible.
And if I can get more natural look as well, right?
Yes, and so the majority of women today really want that natural look, but they want to still have that fullness. So it's pretty rare now that I walk away from the operation, but I will just because I don't want to have undue complications. And so again, it's a surgeon's preference. I would rather not do it and not even get involved with the operation. So good. Number 2, implants are always under the muscle. I haven't found any reason to shy away from that. 2 big reasons for that. Number 1, I do a lot of breast reconstruction. So breast cancer is near and dear to my heart. If you had a mammogram today, all of your breast tissue is visualized as you don't have implants now. Putting the implant under the muscle or behind the muscle, it will not interfere with the mammogram. So all of your breast tissue is visualized like you don't have one. Putting the implant above the muscle, radiologists tell us that implant can obscure about 15% of breast tissue from good visualization. So in my opinion, it's not safe. I'm not going to put you at risk as a young woman or any woman getting this. If you miss that or you miss an early cancer, it may be a problem for you later on. So implant under the muscle is okay for me. Second reason, the most common problem or the most common complication we come across with a breast augmentation is something called capsular contracture. I don't know if you read about that. So let's go through it, even though you've read about it, just to make sure you understand it. Anytime a surgeon of any specialty puts in something that's foreign, a foreign medical device, we talk about plates and screws for fractures. People have, pins and plates in their ankles, their knees, knee replacements, hip replacements, shoulder replacements, dialysis catheters, spine stimulators, in this case, breast implants. So anything that we put in foreign, these are medical devices, they've been approved. Your body will see them as foreign. It will not reject it. That's one of the fears that, you're going to reject this implant. You're not going to reject it. There's nothing to reject. It doesn't react with your body. However, the body notices that it's not itself. And what it does is it just creates a very thin layer of scar tissue all the way around the implant. All of those other devices I talked about will do the same thing. So it's about as thin as this paper. It's a couple of millimeters. It's actually this nice white covering. It's protective. It's fine. So 10 to 12% of women getting a breast augmentation, though, the capsule itself, not the implant, but your own scar tissue, for unknown reasons, can thicken and tighten. Many times, if you're in that 10 to 12%, it's only on one side. It's kind of confusing, but studies have been going on for years to try to figure it out. There's some theories, but there's nothing that's definitive as to what's causing it. So we do know from the studies that if you put the implant under the muscle, your risk is down to 5%. So you can cut your risk in half just by putting it under the muscle. So 2 reasons. The other reason is that, or a third reason for it, is that the muscle holds the implant in place. As you get older, that muscle's not going to get older. So that implant is going to be independent of the breast. You're a young woman, you're going to go through at some point, probably pregnancies, maybe breastfeeding. Your breast will age independently of the implant. The implant above the muscle, over time, it has a little bit of weight to it, will start thinning out your breast tissue, thinning that skin, and you can start getting sagging because of the implant itself. Behind the muscle, wherever you put it, for that 30 years it's going to be behind it, the muscle holds it in place, the breast is completely independent. Okay?
So what you're saying, if you could describe again the layers of what's happening under here, and then how that affects or does not affect breastfeeding later on.
Right, so basically the outer skin,
Okay.
and then you have the breast tissue, which is a combination of fatty tissue and breast tissue.
Okay.
Then you have the muscle, the pectoralis muscle, and then the rib cage. So this implant goes between the rib cage and the pectoralis muscle. Breast tissue sitting up here, and I'll tell you when I talk about the incision why that's important, and when you get into those layers, why I do the incision that I do. But so you want to put it under the muscle so the breast tissue is actually not even touched. And so,
perfect.
Yeah, so over time you'd have less scarring, and that's what we want.
Oh, okay. So then that's how they can see from the mammogram the breast tissue without affecting the implant.
Absolutely,
Okay.
and they can see a part of the implant on the image, but you'll see the muscle right in front of it. So it's away from the breast tissue. So in time, you get good surveillance, you want to make sure through the years that you can pick up on something early on. Okay? Remember, 1 in 8 women develop breast cancer. Every woman should be surveilled. Self-exams, mammograms, age 40 and above. You should be able to see everything. Okay? Lastly, the third non-negotiable is where I put the incision. So there's really only one way to do it, in my opinion. Old times, people used to go through the armpit, especially for saline implants. I never liked that. It's too far away, as a high risk of malposition of the implant, capsular contracture, infection. Lots of people still go through the nipple. I don't like that one either, because you actually have to cut through the breast tissue to get to the plane where you want to put the implant in. So that breast tissue is now scarred and damaged. It has to heal the scar tissue. Sometimes you can develop microcalcifications in the scar tissue. That's what they see on mammogram. I've had patients that come in right underneath the incision at the nipple where somebody has put the implant through. They have a divot because the breast tissue has been damaged. It dies away. Now they have a contour deformity. Capsular contracture rate's about 6% doing it that way. Higher risk of infection, higher risk of nipple numbness. If you want to breastfeed in the future with breast implants, going through the nipple can certainly interfere with that. So I stay away from that completely. I go underneath in the fold of the breast. At this time, I usually, when I examine the patient, I'll show them right where the incision is. The edge of the muscle from that incision is about this far away. I can see the edge of the muscle, I dissect to it, go right up under the muscle, it's very clean. I can see every muscle fiber, every blood vessel. The breast tissue is sitting on top, I don't even touch it. It's completely pristine. The implant goes under the muscle, there's no damage to the breast tissue at all. The nice thing is, with that precise pocket you can build, patients worry about blood loss. When I get through this, because I can see everything, you may lose a teaspoon of blood through the whole surgery. It's a very dry operation. It's very easily seen. I have a headlamp on so I can see everything. The implant goes right in, and then you can close the incision. Nice thing about that incision, you can't see it. You have to lift your breast to see it. It generally heals very nicely. It's the least painful. You can use it over and over again if you need to, but here's the nice thing about it. Your capsular contracture rate with that incision under the muscle is 2%. So you can go from 10 to 12 all the way down to 2 just by doing those things, that it's staying under the muscle. Little incision about this big, stitches under the skin, so you have 3 layers of stitches that dissolve, and I seal it with glue so there's no external stitches. So taking it through that way, it's a very common operation. Your risk, really the highest risk, is about 2% for malposition and capsular contracture. So we don't see capsular contracture much anymore. It used to be a lot more back in the older implants, and a lot of implants being placed above the muscle.
How long is the whole procedure?
If it's a straightforward breast augmentation, less than an hour.
Okay. And I know it's just a small scar, but how long does it take to heal? Like, how long will it take to see the full results of this?
So it takes about a good 6 months for it to really start to really fade, where you don't see it, you won't feel it anymore. Scars remodel for about a year, but by 6 months after surgery, you won't even feel it anymore. Most patients after the surgery are back to exercise in 3 weeks. 6 weeks it takes for all of the scar tissue to be laid down in the incision, and also that capsule to be formed. So at 6 weeks, I let women go back to really anything that their body lets them do. So you can be back to running, jumping, jogging, push-ups, everything. At 3 weeks, I let patients go back to non-impact exercising, which means walking, Stairmaster, elliptical, spin, cycle, swimming. You can even lift weights. You can lift weights in your shoulders, your arms, your belly, legs. I just don't let you do anything across the chest. So no push-ups, no bench presses, anything like that. Stay away from yoga and Pilates, a lot of chest work. I make them wait 6 weeks for that.
Okay.
So most women are back to work, depending upon the job, within the week. If it's a strenuous job or you have a lot of pushing and pulling, it may be up to 3 weeks.
And I've heard elsewhere online that it can take a while for the implants to settle and look more natural. Is that true, or how does?
Right. So let's talk about things on the internet now.
Okay.
So there's a term on the internet called fluff, and I think what they're trying to describe is right at the beginning, of course, everything's swollen, it looks surgical. You get a lot of swelling in the muscles, but if you're putting it under the muscle will spasm for the first few days. So a lot of my patients don't have a lot of pain, but they have pressure. So I treat them with a very low dose of Valium, and it takes the pressure sensation away. I also give a low dose of a pain medication. Again, most patients use them for about the first 2 to 3 days, and then it's over. That swelling takes usually 3 to 4 weeks to kind of settle down. You read on the internet about the implant kind of moving down into position. I think that should be, maybe sort of an optical illusion, because as that swelling goes down, you'll see the implant more. If the surgeon has the implants too high, that implant is not going to move down into position. It has to be in the right position at the time of surgery. If it's not going to move into position. So one of the things I show ladies right at the beginning, the first time, 4 or 5 days after surgery, at their first post-op visit, we take down all the dressings. I show them, yes, this is not the implant. I have them feel it, and then I have them feel underneath the breast. You can feel the implant right there, to reassure them that the implant is in the right position. The other thing that I have ladies do, because there's a lot of things out there, you can't lift your arms above your head for 6 weeks. First thing, 4 or 5 days later, I have my hand above their head. I have them reach up with both hands and touch my hand. So they know they can lift their hands above their head. You can shower right away after that, not in the first few days, but right after that first visit, you can shower, soap and water, you can use lotion. I have women wear sports bras that open in the front for the first few weeks, and then you can go to any sports bra they're probably going to be a good 4 or 5 weeks until they, you know, feel more comfortable not wearing a sports bra. That doesn't mean you have to wear the sports bra all the time. So once you get out of the first 2 to 3 weeks and you have to wear, you know, a regular bra for some things, you can. It's not a problem. So, but that gives women the confidence to do their own hair, wash their hair, go through their daily activities, pull sweaters over their heads, pull things out of the cupboard or the closet without much of a problem. So yeah, so those are the things. The other things that are on the internet, we talked about with a couple of patients today. Number one, there's something out there that you have to replace implants every 10 years. It's ridiculous. Saline implants on average will last 5 to 10 years longer than that. These will last good 20 years after that. So there's no sense in replacing something in 10 years. If your saline implants are 18, 19 years old and they're still intact and your breasts are still soft, you just keep on going. Don't replace them unless you want to. Silicone implants, if you're at 30 years, your breasts are still soft, everything looks the same, 31, 32, 33 years. So I usually recommend patients be seeing every few years, especially after the 10-year mark. Just be seen by a board certified plastic surgeon. Let them check your implants, make sure there's no issues. And that's just sort of a safety thing. There are worries that implants that rupture, especially silicone, there's stuff on the internet about it's going to get into your tissue. If you breastfeed, babies are going to be drinking silicone in the breast milk, which is absolutely ridiculous. That capsule that forms around it, it just sits in there. You'll know your breast will start to change shape a little bit. You'll know that something's a little bit different. It's not going to be anything you feel, if it does rupture. I've only had a couple of ruptures with these implants in the last 14 years since they've been out. And they were non-traumatic. I've had ladies, unfortunately, in some severe car accidents and things like that, and there hasn't been any rupture of the implants under those circumstances. So they're pretty durable. They last a long time. Even saline implants are durable as well. So.
Well, I'd love to talk about sizing. So what size are these, and does that equate to a B, C, D?
Right, so good question. I do not talk cup sizes with women.
Okay.
So unfortunately, women are taught at a young age that you're supposed to sort of label your breast by a letter, and it's irrelevant. Bra companies do not use the standard A, B, C, D anymore. They do label things as C's, D's, and whatever, but there's no uniformity. So you might just, at this point, you may go buy different bras in different companies. You might be a C in one, a D in another, a full B in another one. So to actually put you into a cup size is nearly impossible. So when I size women, we're going for the look. I want you, when you try them on, and we'll go through that in a little while of how I do it, I want women to look at the different sizes we use and go for her look. And whatever look she likes, it doesn't matter what the cup size is. She's going to like that look. That's the look that's going to give her the comfort. It's going to give her the confidence. It's going to make her feel comfortable in anything that she wears. What difference does it make if it's a C, a D, or a Q at that point, right? And remember, I'm only going to give her the implants to try on that fit her anatomy. So she's not going to be too big. The nice thing about doing it that way is women's satisfaction afterwards, because you always hear about, I wish I'd have gone bigger, or I'm too big, or they picked the wrong size. The woman gets to pick it. She knows where her comfort level is. And so as long as she's in her comfort zone, she's going to be happy afterwards. So there's also stories about, women and the surgeon talking about a size 300, and she goes out with a 500. It's not going to happen because I know the parameters of what she likes. The other thing is women might come in and say, just make me a D cup. Well, what I think is a D and what you think is a D might be two different things. So for instance, a few months ago, I had a lady that came in and who really just wanted to talk about cup sizes. So I said, okay, well, let's try them on. So we went through the sizing, and when she was sizing, what I thought was a D was a certain size. She actually went up 2 more sizes in the implant, and then she said that's what she liked. That in her mind was a D. So if you relied on what I thought was a D for her, she would have been unhappy. This way, I have an actual number of volume. If you say, this is me, this is what I like, I know that if this implant is a 340cc implant, I know it's concrete. And so we might be 310, we might be 340, so one size up, one size lower, depending upon the ribs and things like that. So the woman can go into surgery knowing that she already has picked it. She knows what she's going to look like coming out. And
Mm-hmm.
That's the easiest way to do it.
And there seems to be a lot of variables, like the chest wall could be different. There's maybe different breast tissue in each breast.
Right.
How does that work when you go into a surgery and we have 340? Does it ever vary when you get into surgery then?
Yeah, so basically, once we get through the talk that we've already been through, and I've answered all the questions, and we go through any questions that she has. We talk about getting back to work, back to exercise. What can she do with the kids? How much can she pick up? All of those questions I answer. Then at that point, I usually step outside, let her change into a gown, and then I come back in and I do several things. I'll examine her, take those measurements. There's certain measurements that we all take, and then we look together in the mirror. At that point, then we can discuss. Here's what I see, and here's what she sees. Now we're looking at it together. So at this point, I can tell her, is this going to be a straightforward augmentation? Does she have a little bit of sagging? Does she need some type of a lift? Does she need a lift on one side, or a certain lift on one side, a certain lift on another side? Because it can all vary. Women also have this idea that, you know, as you get older, or especially after breastfeeding or even just pregnancies, you lose that fullness in the upper part of the breast. Women equate that with sagging. Sagging is really the relationship or the placement of the nipple on the chest wall in relationship to the fold of the breast underneath. So if that nipple is at the fold or above, there's no sagging. It doesn't matter if you have that concavity above. It's the relationship with the nipple. So the other thing that women kind of think about is that they think their breasts are kind of low. They want the lift and lift them way up here. You can only lift the breast to just above the fold. And so I go through that with those ladies as well. So we talk about it. Talk about the size of the areola, the pigmented tissue around the nipple. Some women are uncomfortable with the size of the areola. Sometimes it's too big. So we talk about that as well. So at that point, then we can talk about, you know, you might need different sizes of implants. You might need whatever she needs at that point. And we kind of get on the same page of what's going to be required at the time of surgery. At that time, I take some photographs, and then I have her put on a sports bra and a shirt. And then we just go through the style that I like. Again, it's mostly this style. So we go through, and I kind of get a feel. I've been doing it long enough. I kind of get a feel for what I'm seeing and what she's told me at the beginning, what her goals were. Then we'll just start the process. And I'll say, okay, let's just start here. And I usually start a little lower, because when you don't have a lot of breast tissue and suddenly you're putting in an implant, it's a shock. So you want to start low and bring them sort of up to her comfort level. And it's really a lot of fun for me at that point too, because then I can say, okay, I think in my mind, I think she's going to be a 375 or whatever, and then we'll see what she settles out. So as she starts to look in the mirror, I do the first one I put in on one side, and she can see where she is today and where if she had that implant in. Question I ask is then, are you comfortable? If she's comfortable, then I'll put another size on this one size up. Are you comfortable? And a lot of times women will just kind of go through comfortable, comfortable, comfortable. And what I tell them at the beginning is, I want you to pick the size that's slightly too big. You'll only know it when you see it. Okay, it's hard to describe, but you'll know it when you see it. So it's great, because every woman will go, good, good, comfortable, yes, I like it. And then as soon as you get to that gray area, all of a sudden she's like, huh. She'll pause, she'll wait, and I know that's where the tipping point is. So I'll say, okay, hold that thought. I give her one more size up. Now, sometimes, rarely, she'll say, ooh, maybe that is okay. But usually, once they get to that gray zone, the next one up, they'll know, and they'll look at it and go, it's too big. So they know comfortable right away, and they know too big right away. That gray zone that's where the implant is. And I said, that's your size. So we know you might be 375, 340. We try to balance out as much as we can at that point. And sometimes it's a range. So you might be 340, 375. So I know where her comfort level is, and that's sort of going in. I write it down, put it in my notes. The night before surgery, I go through everything. The nice thing for me is I have a whole series of sizers in the operating room that are sterile. I also have a consignment of implants that run from 255 up to 560. So I have all those sizes to choose from. Now again, if we choose a 340 to 375, you're not going to come out with a 500 and a 300. You're going to be in that range, but I have a little bit of wiggle room in case the chest wall is a little bit different. Otherwise, what I would have to do is order all the implants. You'd have to order so many sizes above and below and do all that stuff.
So breast augmentation could fix asymmetry then?
Yeah, and so for a lot of women, it's the size of the implant, so they might be, and I've had some that are literally 285 on one and 400 on the other. There's that much disparity in the volume of the breast. But sometimes it's a little bit of volume difference and it's a little bit of sagging difference. So you might have more skin on one side. So you might need a full mastopexy on one side, a periareolar mastopexy on the other, a little bit bigger implant on that side, a little bit smaller implant on this side. So it's going back and forth. So the straight augmentation usually takes me, a little less than an hour. But when we start doing a lot of asymmetry, it might take 2.5 hours. So it's a lot of fussing and a lot of, having the patient, they'll raise the back of the table up, and then the surgeon can look and see, how close they are and do different things, swapping in and out, until you want to get that symmetry as close as possible and the incision's in the right spot. So.
Perfect. I've never had a procedure. Could you just quickly walk me through what that day would look like for me? Sure.
So in any procedure, you would come in about an hour before. So all of my surgery is done at a surgery center in Monroeville. It's owned by Allegheny Health Network, so it's owned by a major hospital. It's the highest level of credentialing. I use a board-certified anesthesiologist, certified nurse anesthetist, so they're with you every second of the operation. So generally speaking, this surgery is done under general anesthesia. You're completely asleep. The nurse anesthetist is there every second. The anesthesiologist is in and out. I'm with you every second of the operation. The nice thing is I get one of two scrub techs, and I get the same circulating nurse every single time. So they know my nuances. I've been at that place over 6.5 years. I've done more than 3,000 surgeries. So they know my nuances. They know what I like. So when you go in there, they've done all these surgeries many, many times. They know exactly how I position everything. So they will usually have you there about an hour before surgery. You go into the pre-op area. If you're the first patient of the day, I usually come in good half an hour, 45 minutes before surgery starts. Come in, mark you, make sure you don't have any questions. Anesthesia will come in and talk to you. The nurses will take you through things. They'll take you through some of the post-op things that, questions that you might have. And then they get you ready for surgery. You go back into surgery. In this case, if it's a straightforward augmentation, it takes about an hour. With the anesthesia, it feels like 2 minutes, you're in recovery.
Wow.
Recovery is usually an hour to an hour and a half, you go home.
Wow.
So my procedure for me is then later that afternoon, I call every single patient from my cell phone, talk to them, make sure they're feeling okay, any questions that they might have, and then any questions they have, they can call me or text me directly. So it's a pretty straightforward procedure. The nice thing about the surgery center, they kind of move you through pretty nicely, and it's sort of routine all the way through.
Great. I think I'm all good. So
Good.
This has been great. Thank you so much.
Good. Well, I hope this helps. It kind of takes you through what a usual consultation would be. If you're going to have a consultation with me, plan to spend 45 minutes to an hour, because we would do the sizing that day. Please bring a sports bra. You must have a sports bra. Any bra that has padding in it won't work. So sports bra and a shirt or a dress or something that you might want to be sized in. So any questions you have, please let us know. Contact us. Go to our website, bellissimoplasticsurgery.com. You can call us at 844-496-6647. Follow us on Instagram, Twitter, Facebook, all the other ones. So thank you so much for joining in, and we'll see you next month.